Today, we're going to talk about a group of systemic inflammatory disorders called the Spondyloarthropathies. This category includes ankylosing spondylitis, reactive arthritis, and psoriatic arthritis. These conditions are also associated with inflammatory bowel diseases, such as Crohn's disease and ulcerative colitis. What makes spondyloarthropathies unique is where the inflammation occurs. It tends to show up at the sites where tendons, ligaments, and joint capsules attach to bone. This can include areas like the sacroiliac joints, which are very commonly involved. Inflammation of the periosteum, or the layer covering the bone, may also occur. These disorders often appear in young adulthood, with men affected more than women, and they frequently run in families. In fact, the genetic marker HLA-B27 is strongly associated with them. Another important thing to remember is that patients with these conditions have a higher risk for cardiovascular disease. This risk may be related to chronic systemic inflammation, along with decreased physical activity caused by pain. Let's break down the major conditions within this group. First, ankylosing spondylitis, or AS, is a chronic inflammatory disease of the spine. It is diagnosed more often in men and usually begins in the late teens or 20s. The disease affects the cartilaginous joints of the spine, causing them to become rigid and immobile. Over time, this leads to decreased flexibility and kyphosis, or a stooped posture. Patients usually complain of back pain, which can be severe enough to mask other issues, such as cervical fractures. As the disease progresses, large synovial joints like the hips, knees, or shoulders may also be affected. The complications of AS can extend beyond the spine. The heart and lungs can become constricted due to changes in the chest cavity. Osteoporosis is common in this population, and patients are also at risk for conduction abnormalities, aortic insufficiency, and pulmonary fibrosis. In advanced disease, the spine may fuse completely, which further limits breathing and mobility. Next, let's look at reactive arthritis, sometimes called Reiter's syndrome. This is called reactive because it usually develops after an infection, most often in the gastrointestinal or genitourinary tract. It typically affects young men and is characterized by the triad of arthritis, urethritis, and conjunctivitis. Patients may also have dermatitis or ulcers on the mouth and penis, and low back pain is a common complaint. The third condition is psoriatic arthritis, which occurs in people who already have psoriasis, a common autoimmune skin disease. About 7% of patients with psoriasis will also develop psoriatic arthritis, usually between ages 30 and 50. Men and women are affected equally. Psoriatic arthritis can involve synovitis, polyarthritis, and sometimes spondylitis. A key clinical clue is inflammatory back pain that improves with activity but worsens at night, which differentiates it from mechanical back pain. Radiographic evidence of sacroiliitis or spondylitis can support the diagnosis. Other painful sites may include the Achilles tendon, plantar fascia, or tibial tuberosity, due to inflammation where tendons and ligaments attach to bone. Now let's move into management. The main goal is to reduce pain and maintain mobility by suppressing inflammation. For patients with ankylosing spondylitis, maintaining proper posture is crucial because if ankylosis or fusion of the spine does occur, you want the spine to be fused in the most functional position possible. Regular exercise and muscle strengthening are essential to maintain range of motion and quality of life. Pharmacologic management begins with NSAIDs, which are the first-line therapy for all spondyloarthropathies. However, long-term use must be carefully considered, especially in patients with cardiovascular, renal, or gastrointestinal issues. Disease-modifying drugs such as methotrexate, sulfasalazine, or leflunomide can help with peripheral joint and skin disease, but they don't always prevent changes in the spine. Corticosteroid injections may be used during flares, though long-term oral steroid therapy is not recommended because stopping them may trigger psoriatic skin flares. For psoriatic arthritis, the treatment target is now disease remission. Anti-TNF agents like etanercept, infliximab, adalimumab, golimumab, and certolizumab pegol are commonly used. Other options include apremilast, a PDE4 inhibitor, and ustekinumab, which blocks interleukins 12 and 23. In severe ankylosing spondylitis with debilitating kyphosis, surgery may be needed. An osteotomy of the spine can correct deformity, and in some cases, joint replacement may be considered. Finally, nursing management. The main interventions focus on symptom relief and maintaining function. Patients with these disorders are often young men who may be worried about their ability to work, play sports, or maintain an active lifestyle. Helping them maintain activity, posture, and independence is key. Emotional stress, depression, and the long-term burden of chronic illness must also be addressed. Supporting patients in adapting to changes while encouraging physical activity and healthy coping strategies is an important role for the nurse.